We'll also have a video of a patient with a penile prosthetic, as well as we'll give information to our local Oklahoma patient advocate, Bob Daniel. It'll show up in the chat portion of the presentation. His phone and his email will both be available. Our phone number to our office, if you have any questions that want to talk on the phone about, or interested in scheduling an appointment, I will put that phone number in the chat right now. You can also reach out to us on the Facebook page or via Twitter. So what is our goal today? Our goal is to educate men and their partners about erectile dysfunction treatment options. So we want to make it as interactive as possible. So feel free to ask questions. We'll address them as they come along, and you'll get to hear from Stan at the end to talk about his journey through getting his ED from untreatable to cured. So what is ED? What causes ED? Treatment options, questions, and answers. So erectile dysfunction is the inability to sustain an erection sufficient for sexual intercourse. And that usually starts as a tendency to only have brief erections or not be able to maintain an erection through the completion of intercourse, including ejaculation. An inconsistent ability to achieve an erection rich enough for penetration. So that's kind of the next iteration, is the erections don't ever get hard enough to penetrate. And then the end stage, or the final stage, is a total inability to achieve an erection. If you have erectile dysfunction, it's certainly you are not alone. So 30 million men in the United States have some form of erectile dysfunction. 1 in 4 men experience ED, and as we get older, it becomes much more common than that. So for men in their 50s, up to 50% of your friends have some amount of erectile dysfunction. May not be total, may be just difficulty maintaining, but and once you reach your 70s or 80s, it may be 70 or 80% of your friends have trouble with erectile dysfunction. So you're not alone. It's not a normal consequence of aging. Most men with ED can have an orgasm and still father a child, but those issues become much more difficult if you don't have an erection that lasts towards orgasm. It's important to note that erectile dysfunction is not a normal part of aging. It's usually a disease process that is progressive, but can be treated and can be fixed. Research has shown that 80% of men with erectile dysfunction can trace it to some physical problem or disorder. And so, not often, but we do see some men come to our office and, is this a anxiety problem, or is this all in my head? That is rarely the case. Almost always it's tied to some type of physical illness. Injury, such as a brain or a spinal cord injury, can cause an issue. Disease states such as diabetes, heart disease, an operation such as prostate gland removal or colon surgery, and some lifestyle habits or choices or substance use such as tobacco, drugs, alcohol, or medications. What about your heart? There's a new concept that erectile dysfunction may be an early marker for cardiovascular disease. And I think there's really something to this. The penis is a vascular organ. Loss of erectile rigidity is the earliest sign of endothelial dysfunction. And endothelium is a part of the blood vessel that makes it work. And the same part of the blood vessel that gets clogged in coronary plaques. And endothelial dysfunction is an early marker for cardiovascular disease. And we know that the penile artery is about 6 times smaller than the artery, the main arteries that go to the heart. And so some new research has shown that erectile dysfunction can preclude heart disease or your first heart attack by an average of 6 or 7 years. And so a new thing we are doing is if you have erectile dysfunction, we are talking to you about seeing a cardiologist pretty early on in the process. And so if this is you, if you have erectile dysfunction, it's not a bad idea to have a cardiac evaluation. So risk factors for ED, what are some issues you may be having or things that are going on that may make you more prone to have erectile dysfunction. So first, even though age is not the cause, as we get older, we typically have more of these other things, diseases, medications, and lifestyle issues that sort of creep up and factor in. So as we get older, erectile dysfunction is more common. Chronic disease such as high blood pressure, diabetes, depression, cardiovascular disease are well-known risk factors. Certain medications are known to cause erectile dysfunction, and the two most common are medications for high blood pressure. The first one is the thiazide diuretics, and those are the water pills that a lot of people take for high blood pressure, and then beta blockers, which are also good for the heart, but may not be so good for the erection. So both of these medications are known risk factors for erectile dysfunction. Incidentally, if you're looking for a blood pressure medication that doesn't really affect erections, the ACE inhibitors or the angiotensin receptor blockers are the good options for those. ACE inhibitors are high blood pressure medication that end in PRIL, like captopril, lisinopril, enalapril, are all ACE inhibitors that have very little impact on erections. Lifestyle choices, I wouldn't say stress is a choice, but managing stress and learning and coping mechanisms to reduce stress in your life may help your erectile function and, just ease the tension in the bedroom. Alcohol abuse and smoking are certainly modifiable things that you can do that can cause erectile dysfunction. However, stopping smoking may not necessarily result in improvement of erectile function, but it's good for many other things anyway. So aging increases the risk of erectile dysfunction because of increased prevalence of chronic disease, psychological or relationship or partner issues, and just the body doesn't work as well as we get older. An interesting thing in this presentation is the 3 out of the top 4 reasons why men age 45 to 64 go to the doctor are all risk factors for erectile dysfunction. So hypertension, diabetes, and disorders of metabolism or a high cholesterol are all risk factors for erectile dysfunction, and top 3 reasons why men go to the doctor. Another common condition that's often associated with erectile dysfunction are diabetes and hypertension. So factors impacting erectile dysfunction in patients with diabetes. So as you get older, you've usually had diabetes longer. The duration of diabetes, how well your diabetes is controlled will certainly impact how well your erections work. So if you have a A1C of 9 or 10, then you may be more likely to have erectile dysfunction. If you have a well-controlled A1C down in the 6 or 7 range, then it may be a longer period of time with diabetes before you develop erectile dysfunction. And certainly diabetes affects the nerves and the blood vessels, which are critically important to how erections work. High blood pressure of men with high blood pressure, 68% report some amount of erectile dysfunction. And men with severe erectile dysfunction, 45% have high blood pressure. So, and the amount of vascular disease you have correlates to how much erectile dysfunction you have. So the worse your hypertension is controlled, the longer you have it, usually the worse the erectile dysfunction. Risk factors for chronic disease, diabetes, prostate disease, peripheral vascular disease. You can see here that diabetes is the biggest risk factor, 4 times more likely to get erectile dysfunction with diabetes. High blood pressure is almost 2 times as likely to get erectile dysfunction than somebody without without high blood pressure disease. Prostate disease, 3 times as likely to have erectile dysfunction than somebody without prostate disease. So, prostate cancer in of itself is not a risk factor for erectile dysfunction, but treatment for prostate cancer is a well-known risk factor for erectile dysfunction. So radical prostatectomy, or removing the prostate, can damage the nerves and blood vessels. Radiation therapy over time can damage blood vessels and nerves, leading to erectile dysfunction after prostate cancer treatment. Smoking medication. Smoking increases the risk of ED twofold. Smoking certainly damages endothelium, which impairs vessel flow to the penis, which produces erectile dysfunction. Former smokers have less erectile dysfunction than current smokers. And we talked about the 2 high blood pressure medications that also cause erectile dysfunction. So how does an erection occur? So the first thing that's going to happen is sexual incitement, either through thoughts or through stimulation, manual stimulation, either self or partner. And then that stimulation or excitement causes the nerves to stimulate the penis, which causes dilation in the blood vessels. And hormones work together, allowing blood flow to increase into the penis. The blood becomes trapped in the 2 spongy chambers, which are these chambers here, begin to fill with blood and elongate the shaft of the penis and increase the girth in the shaft of the penis. And then as those begin to fill, they get hard, and they compress these veins that allow blood out of the penis, creating the erection. So you have increased input into the penis, decreased output, you get a hard, straight penis, and the result is the erection. This tube here is the urine tube, where the urine and the ejaculate comes out. So that is causes and risk factors for erectile dysfunction. Next, we're going to go into treatment. Any questions before we move into treatment options? If you do, don't forget to type your message here in the Q&A. So oral drug therapy is, this is the most common treatment for erectile dysfunction. Everybody knows the Viagra and the Cialis commercials. There are 2 other agents on the market, though those are rarely used, Levitra and Stendra. Viagra and Cialis are now both generic and have gone pretty cheap. You can get, doses of either one now under $5 a dose. So these pills may help achieve erection in response to sexual stimulation, and that's real important. These medicines really need foreplay to get the most out of them, and they're not necessarily automatic. They are effective in up to 70% of cases, but 1 in 3 men may find that the pills don't work for them. You do have to take them an hour before sexual activity to get the most out of them. Cialis works well with or without food. Viagra works best on an empty stomach. And alcohol can impair, even just a couple of drinks can impair how effective either of these medications work. Side effects of the medications: headache, flushing, muscle aches, blue halos, upset stomach are all well known. They usually go away as the medicine wears off and don't have harmful long-term ramifications. Another common thing that I tell my patients when I start on these medications: if you're on Flomax for an enlarged prostate, you want to take Flomax and the Viagra or Cialis at least 4 hours apart. The next option is the penile injection therapy. This involves a shot. It's an injection that goes into the side of the penis. And usually an erection will onset in about 5 to 20 minutes. For those of you that listen to sports radio, this is what they're selling at the $99 office visit. However, there are some risks to this medication, and any urology office can prescribe this as well, usually at a much cheaper rate than you find at the commercial men's clinics or the cash paying men's clinics. Risk of erection lasting longer than 4 hours. That's in all the TV commercials for the pills. That never happens with the pills, or almost never happens with the pills. But that can be common with the shots, especially if you're at a titrating up or going up on the dose. Bleeding at injection site is usually managed with just pressure. Pain at injection site is pretty common. That can happen in 10 or 15% of men using the injections. They do require training. Bruising, prolonged erection is a possibility. One of the least talked about things is the risk of shots and causing scar tissue in the penis. So 5% of men who use the shots will develop scar tissue that can result in curvature and shortening of the penis. Men, long-term tolerability: men who start the shots, less than 1 in 5 are still using the shots of the year. And just some men aren't comfortable with sticking needle inside the penis. So very reasonable concern. So may not be for everybody. Vacuum devices were all the rage when Medicare was paying for them. But now most insurers are not covering them. They are pretty effective. 80% of men who try one can get a usable erection. I tend to recommend this for my birthday and anniversary folks, people who may only be intimate every couple of months. That's a good option, but there's some comfort issues with it. It is cheap. You can usually get one medical grade device, one for between $100 and $300. But there is some dissatisfaction. The temperature of the erection is a little cool, can be a little blue appearing. It's difficult to ejaculate with the ring in place. A lot of men have trouble getting seals with the erection. You have to keep shaved around the head of the penis so you can get a good vacuum seal. Similar issue with dropout. 1 in 5 men who are prescribed a vacuum are still using it at 1 year. Insertable drugs. These came out about 10 or 15 years ago. They have very little market share in 2019. It's a suppository that's inserted into the tip of the penis, and then you rub the tip of the penis and the medication is absorbed. It does have some burning issues, pain, but the biggest issue now is the cost. It's usually between $50 and $75 a dose. So I don't see very many of my patients using this medication. The malleable prosthesis is the first procedural option for treatment of erectile dysfunction. It's easy to activate and deactivate. If you have issues with dexterity of the hands, it could be a good option. Totally concealed within the body. It's less expensive than an inflatable, but for most people, the insurance will cover, 100%. The downside to that is the erection does stay firm even when the penis is bent down and the device is in the not erect position. It is firm. Most people that elect to go a procedure or a curative route elect for the inflatable penile prosthesis. And this is a picture of the Coloplast Titan. It's easy to use. It's a one-step deflation. You press the button, squeeze the penis, and the device goes down. We're going to show you a video of that in a minute. It's totally concealed within the body. Nobody knows you have it, but you and your partner. If you go to the gym or have a grandchild sit in your lap, there's no one's going to know it's there but you. So acts and feels more like a natural erection than the vacuum device does. Expands the girth of the penis. And then when it's deflated, not in use, it's soft and flaccid like a normal penis would be. And here is a quick demonstration of how the device works. So this is a Titan Touch inflatable prosthesis. And there's a control pump inside the scrotum. It's completely hidden. We put all three components in through a tiny incision in the scrotum. And when the device is ready to be used, it usually takes between 6 and 7 squeezes of the control pump to get a firm erection. Now, the bigger your penis may require, more pumps, so that's not necessarily a bad thing. And so the penis stays erect as long as you want. One quick squeeze of the scrotum and squeeze of the penis, and the device is deflated. So that's how the device works. We've talked about, the 5 major treatment options for erectile dysfunction. The penile prosthesis is a procedure. Any procedure does have risk. The main one we worry about is infection. And now all the penile implants are covered in an antibiotic protective coating. And we do lots of things to prevent infection. So we make sure your urine has no sign of infection prior to the procedure. We give you some special soaps to perform an antibacterial shower the night before. We scrub your skin with a special prep 10 minutes prior to the procedure. We scrub our hands for 10 minutes prior to the procedure. We do the procedure skin to skin in under an hour. And you stay overnight for IV antibiotics after the procedure, and then go home with 5 days of antibiotics following the procedure. So we make every effort to reduce this. We follow the AUA guidelines in regard to which antibiotics we choose. The penile prosthesis may make latent natural erections as well as other treatment options impossible. So once you go with a penile implant, this is your cure. You usually cannot go back except for a vacuum. Erosion is pretty rare. Migration or unwanted movement of the device is very rare. Chronic pain in less than 1%. Device malfunction. So 10 to 15% of men, or 5 to 10% of men will have some kind of mechanical malfunction in the 10-year follow-up. So they're pretty reliable for a inflatable device inside the body. We have our first question. How painful is the implant surgery and how long is the recovery So you would stay overnight. You would get pain medicine overnight while you're in the hospital. Most patients are off of pain medicine inside of a week. Recovery, as far as going back to work, can be as short as a few days up to a week. That's where most people go back to work. Some people may need off up to 3 weeks, depending on your pain tolerance and swelling. The device is not able to be used until 6 weeks, but you're usually able to inflate and deflate device at the 3rd week post-op visit. Insurance coverage information. Most insurance plans, including Medicare, cover the procedure. If you have questions about reimbursement, certainly we have gals at the office that can show you what your out-of-pocket expense would be. Partner satisfaction, that is an excellent question. So partners have had this, partners of patients who've had this put in do not notice a difference between that and the natural erection. 85 to 90% of women would recommend this to the husband of a friend. So it is very few partners of women in their 70s can sustain an erection for 20 to 30 minutes. So this is a big driver of patient satisfaction. Men who've had it put it in, 95% would recommend it to a friend. Learn more. So there's more information available at Coloplast Men's Health. If you have questions about Peyronie's disease or male urinary incontinence, testicular implants, we can discuss those. We have a patient educator. His name is Bob Daniel. We will plug his information into the chat box. You can call or email him. He'd be happy to discuss what life is like after a penile implant and what it was like going through the procedure. Here's a quick video from Stan, and he's had the penile implant performed, and he'll tell you his story.
Hi, my name is Stan Rydelic, and I'm 61 years old, and I live in South Carolina.
I'm Teresa Rydelic. I'm 60 years old, and I met this gentleman when I was 15 years old, and we've been together ever since.
I've been married to my wife, Teresa, we've been debating this, 39 years. 39 years. 39 years of bliss. About three and a half years ago, I ended up getting ill. I thought I had the flu. It turned out that I had liver failure, and so unfortunately, or fortunately, I had to have a liver transplant. As part of the procedure to nourish my liver, I found out what they did is they rerouted some of my blood flow, and so I ended up with a condition called arterial insufficiency, which basically means that the lower part of my body had insufficient blood flow. After I had my liver transplant and I was feeling well again, and then I found out that things were not happening romantically. It was kind of a surprise. So what I did was I asked my general practitioner, and so he immediately said, well, you know what? All you need is some Viagra. So what he did was he gave me a prescription for Viagra. I went home. I remember that evening, I was thinking, oh, how wonderful, Viagra. Of course, it's going to be a great evening. So what I did is I put some music on, poured some wine for my wife, lit some candles, and guess what? Nothing happened. So I went back, and and every time we're going in, it's just like it's 2 weeks or so between appointments, and it's still like nothing's happening, and you start to really get very discouraged. So the doctor gave me a choice. He says we could use vacuum erection devices, he says, or we can also use an injection. So I said, let's try the vacuum thing first. That was horrifying. Well, first of all, in my opinion, it was horrifying. It didn't really work. So that was like a one-time shot. And then we tried it was Trimix that I tried. And so I thought that was going to be great. Went home, and again, since there was a tiny bit of success, I thought this was going to be a great evening. So you try to get all romantic, and then you say, oh, excuse me, honey, I have to go into the bathroom and inject my penis with Trimix. I did everything that I could, and quite honestly, I had never even heard of a penile implant. And so when this doctor I went to, he was a young gun, kind of like, cutting edge, and he says, I think the only thing that we could do, he says, to really guarantee that you can get an erection is a penile implant. So Teresa was a part of the process. She came to the doctor's office with me, and what we did is we had the discussion about it, penile implant, and she said, look, if it means that much to you, she goes, I want you back how you were. I want you happy. A couple things came up. The first one that I worried about was the procedure, a painful procedure. And quite honestly, I was told, and after experiencing it, it's an outpatient procedure. It takes less than an hour, in many cases a half an hour or less. Another thing that concerned me also, and this one's going to sound really, really very strange, but I really worried that I would have the desire to have sex.
Well, it's kind of ironic because that's exactly how I felt. I felt like, well, he's going to get this implant. We hadn't had sex in so long. Maybe that chapter's over. And I think that a lot of women worry that they're not going to be ready for this new adventure like they were. And it actually has been a renewal of our relationship in one area. And so I'm glad. I'm just glad it's freeing. It's taken on where we can be spontaneous, just so different than years before.
There was a romance.
Yeah.
There was a spark that was put back that we didn't know went out. The thing that's really, I think, been wonderful with an implant, with the implant, which I honestly, I don't consider I have an implant anymore. It's just, it's a part of me.
Right.
There's no, well, first of all, from the standpoint, if you look at me, if you saw me in the shower or whatever, you cannot tell that I've had an implant at all. And then also from the other standpoint is you have complete spontaneity. There is never anything where you have to say, okay, you know what, I'm going to take a pill and wait a half an hour for it to happen. If you're in the mood, you're in the mood.
Right.
And it turns back the clock. I mean, I honestly feel like we're in our 20s or 30s.
Since the implant, there's a confidence there that is actually very sexy. And that confidence is something that I think the implant did for us. And I don't worry that it was me, that maybe I wasn't something that he was needing. No, we're perfect for one another, and now we have back our love life. If I could give some advice to someone dealing with this, a couple dealing with this, I would say talk to one another, be honest and open and loving, because the answer may be no. The answer may be, no, I don't want to do this, and it may be, I've been thinking about this. So I think communication is the key.
If I could give a piece of advice to anyone suffering from erectile dysfunction, it is the fact that you have one life, and you have the choice to choose how you live your life and at what level of quality you live your life. So if you're suffering with something like erectile dysfunction, that's fine. You can live with it, but you don't have to. It's something that is so easily fixed, and you could have the quality back in your life that makes you a whole person again.
All right. We're about to wrap up. Any questions from the audience? One thing that a lot of my patients ask is, what about orgasm? Will orgasm be different after a penile implant? And the answer to that is no. So if before the procedure you were able to ejaculate, experience normal orgasm, there should not be any change in orgasm after the procedure. Sensation, we do all of our implants, we do them scrotally, so there's very, very little risk of nerve damage. So usually penile sensation is the same as well. And that's all I have, unless there are other questions. So thank you guys very much. Hopefully it was informative, and please reach out to us or reach out to Bob, our patient educator, if you have any questions or concerns. Thank you.